Okay, I think we are good to go ahead. So welcome everyone. My name is Alex Huffman. I'm the Assistant Director of Support Services here at the Cancer Center. And I am thrilled that you are joining us for another Lunch and Learn, which I know is going to be a very informative session. Just a few housekeeping things before we get started. If you would use the chat feature to submit any questions, and we will get to those at the question and answer section at the end of our presentation today. This is being recorded, and actually we have the lovely ability to send this to you so that you can keep this as a resource and refer back to it if you have any questions or wanted to review any of the information presented. So you will get that at later this week. And then finally, I wanted to make a note too that while we know that you may be joining us because you've had a personal experience with breast cancer, or maybe you've had that in your family, today we're not going to be able to answer specific questions about your care. So if you do have things that come up, we really encourage you to reach out to your oncologist or maybe your medical provider that's overseeing your survivorship care to get those directly answered for you. So now I'm thrilled to introduce Sheeba Cantanelli, who is one of our fantastic physician assistants here at the Cancer Center. And she's presenting on our session called Life and Health After Breast Cancer. Sheeba is a board certified physician assistant here at the Cancer Center, and her primary clinical focus is caring for our breast patients. She did her undergraduate work in biology and psychology at the University of Houston, and completed a Bachelor of Science degree in Physician Assistant Studies at the University of Texas Medical Branch in Galveston in 1996. And after working in primary care for several years, she completed a Master of Science degree in Physician Assistant Studies with a hematology oncology specialist through the University of Nebraska. She has worked in hematology oncology since 2001, again with a primary focus in breast medical oncology. In addition to clinical work, Sheeba is interested in education, and I think that's a little short selling, Sheeba, because you have a fantastic role here as our preceptor and instructor for our physician assistant program, our fellowship program. Sheeba is also a preceptor and instructor with the physician assistant program at the University of North Texas, UT Southwestern, and the nurse practitioner MSN program at the University of Texas at Arlington. And again, she's currently our program director for our Advanced Practice Provider Oncology Fellowship Program. She's also a member of the American Academy of Physician Assistants and the Association of Physician Assistants in Oncology, and she is here today to give you a wealth of information on survivorship. So Sheeba, please take it away.
Thank you, Alex, for that gracious introduction, and thank you to each of you for attending this presentation on breast cancer survivorship, where we have a chance to talk about life and health after breast cancer. I'm very excited to be able to talk about this part of breast cancer care, which is survivorship, where we can, the active treatment for breast cancer has been completed, and we can shift focus, take a deep breath and take a few steps back and look at your health as a whole, and start reshifting the focus to looking at breast cancer surveillance, of course, but also looking at screening for other common cancers, managing adverse effects associated with breast cancer treatment, and then really focusing in on lifestyle changes where we can minimize risk of cancer recurrence and occurrence of other cancers. And this generally just improve your health, wellness, and quality of life. So I feel privileged to be able to have this discussion with you today. So we'll dive in and get started. Okay, are my slides visible to everyone?
They sure are. They sure are, Sheeba.
Okay, great. Well, so I want to specify that I have no conflicts of interest to disclose. So our objectives today with this presentation is to talk about breast cancer survival data and survivorship definitions, discuss what breast cancer surveillance looks like as part of survivorship, talk about screening for other common cancers, discuss potential adverse effects following breast cancer treatment, and then talk about health promotion measures in breast cancer survivorship. So when we talk about breast cancer survivorship, it's really important for us to look at what are the survival data currently, and who and how is this applicable. So breast cancer is the most frequently diagnosed cancer in women worldwide, and it continues to be the principal cause of cancer-related death in women worldwide. So this diagram here by the World Health Organization, published in 2020, you can see just across all continents, breast cancer continues to be or is the most prevalent cancer in women. And I have over my career, seen this updates from WHO over the years, and it really hasn't changed very much. Breast cancer has continued to be a prevalent part of female cancers across the globe. But what has changed and improved is a prognosis associated with breast cancer, which is estimated to be about, the 5-year survival rate is estimated to be about 90%. And the 10-year survival rate's about 80%, which are phenomenally positive numbers. There is an estimated 3.1 million breast cancer survivors that are alive in the United States, and this number is only increasing. So it's really important that we talk about, given this improved prognosis and survival rates, that we talk and focus attention on survivorship care. So when we talk about survivorship care, we have to talk about what is defined as a survivor. So there's multiple different definitions of cancer survivor, and the NCCN, and we'll go over a few of those. So the NCCN defines a survivor as any individual from the time of diagnosis through the balance of their life, regardless of what is happening during the course of their cancer journey. The NCCS, the National Coalition of Cancer Survivors, defines survivors same as NCCN. The NCI, the National Cancer Institute, defines survivors as same as above, but also includes family members, friends, and caregivers. The thought is that patients don't survive cancer on their own. It affects other people who are a part of their lives. And then the EORTC, the European Organization of Research and Treatment of Cancer, defines survivors as any person who's been diagnosed with cancer, has completed primary treatment except for maintenance therapy, and has no evidence of active disease. So, it's important to kind of look at the fact that the wording of survivor and survivorship can certainly have lots of wide definitions. So our presentation today is most applicable to the latter definition of breast cancer survivor, where patients have completed the primary treatment and other than maintenance treatment is not on any other active treatment and has no evidence of active disease. However, there's a lot of overlap in this, because in breast cancer patients, even with metastatic disease, there is long-term survival in a high percentage of patients, and they're in various aspects of their breast cancer care. So there's certainly aspects of survivorship that might be applicable to many beyond this one definition. So there are several evidence-based guidelines that exist that are used in clinical practice as far as survivorship. And the two most common ones that are used are the NCCN guidelines and then the ASCO Combined Breast Cancer Survivorship Guidelines. What do these guidelines review? They make recommendations regarding cancer surveillance and screening. They talk about management of potential treatment-related adverse effects, and they discuss lifestyle measures to promote health and quality of life. So it's important to mention that the survivorship guidelines for breast cancer are essentially the same across the board for all early stage breast cancers, which is defined as stage 1 through 3 breast cancers. And it's the same for all subtypes. So it's not differentiated out based on the different stage or subtypes of breast cancer. Now, the caveat to that is, if based on a patient's stage or subtype, if they're on some form of maintenance treatment, there are specific guidelines that pertain to that. But other than that, the guidelines are same across the board in these categories. So we talked about the two major guideline sets. So here is a visual of what the NCCN guidelines for surveillance and follow-up looks like. And I won't review this line by line, but I wanted to have the visual idea of what this looks like and what we look at clinically to determine these survivorship recommendations. So similarly, the ACS and ASCO have the guidelines that look like this, that make recommendations regarding surveillance and follow-up. And there's quite a bit of overlap and agreement between the ACS and ASCO guidelines and the NCCN guidelines. They're essentially the same guidelines, just with slightly different wording. So based on these clinical guidelines, many oncology practices will formulate survivorship care plans, or SCPs, to provide to their patients. And it's typically provided, the SCPs are typically provided when patients have completed their active treatment for breast cancer and are either going into surveillance or surveillance with some form of maintenance treatment. And what these SCPs typically include are a summary of all the treatments received and then recommendations for follow-up care. So a big part of breast cancer survivorship is, of course, breast cancer surveillance. And so what does that encompass? Breast cancer surveillance includes looking and watching for any signs of local recurrence of the breast cancer on the chest wall or the regional lymph nodes. It entails monitoring for distant metastatic disease. And it also includes looking for a new primary breast cancer. So there are some key recommendations that are evidence-based on evidence-based guidelines, and they all include cancer-specific history and physical. And there's some variation in wording and schedule suggested, but based on the guidelines, this is the common schedule that's followed in clinical practice. So in seeing a patient for a cancer-specific history and physical every 3 to 6 months for the first 3 years. And then every 6 to 12 months, years 3 to 5, and then once a year starting year 5. And so, of course, the follow-up frequency is individualized. It depends on the patient's risk, patient's level of comfort, and just different things the provider and the patient might identify that warrant a different follow-up schedule. But as a general, this is a follow-up schedule that can be seen or expected when you're in breast cancer survivorship. It's, of course, if medical evaluation is recommended anytime in between. If a patient notes any concerning signs or symptoms, we certainly don't want to wait till the scheduled follow-up. We want to be able to address that as soon as those things come up. So one of another thing that the guidelines talk about as part of survivorship and surveillance is mammograms, and there's some different recommendations based on the type of treatment you've had as far as surgical treatment. So if a patient has had a partial mastectomy or lumpectomy completed, then the recommendation is to at least have annual mammograms of both breasts. If someone has had a total mastectomy on one side, then the recommendation is to have annual mammograms of both breasts. And then if someone has had a bilateral mastectomy and there's no significant breast cancer tissue that's remnant, then there's no routine screening that's recommended. And this applies to reconstructed breast tissue as well. So if someone has had a mastectomy and they have reconstructed breast tissue, that does not require any ongoing routine imaging. It's generally recommended to wait at least 6 months from completion of radiation therapy to proceed with any screening mammograms on the radiated breast. And that's because radiation can cause some artifact that can potentially affect the mammogram appearance. But of course, if there's any sort of clinical concern or symptom, then that would forego this recommendation. And we would do the imaging at that time. Same thing with if there's any suspicious findings on physical exam or surveillance, the imaging frequency might be different based on what's recommended by each provider. What about breast MRIs? What is the guideline recommendations for screening breast MRIs? Well, generally, both the major guidelines recommend screening MRI breast for anyone who's considered high risk. And high risk is defined by various entities in different ways. A common guideline to stratify someone as high risk is based on the American College of Radiology, or ACR, recommendations. And these are updated at different intervals. And this is the most recent update in May of 2023 that came out. And per the ACR guidelines, an MRI breast is to be considered in breast cancer patients if they had a breast cancer diagnosis before the age of 50, if they're noted to have dense breast tissue on radiograph, which is described as heterogeneously dense or extremely dense breast, if a patient has a genetics-based increased risk of breast cancer, and if there's any history of radiation therapy before age 60. These are the circumstances in which an MRI breast should be considered as a screening tool in addition to mammogram. If an MRI, a screening MRI of breast is done, this is typically timed 6 months from the mammogram. So every 6 months, there's some form of breast imaging in high-risk patients, alternating with mammogram and MRI. What about other diagnostic studies? What are the guideline recommendations for that in breast cancer patients? Well, per NCCN and the ACS ASCO guidelines, routine testing with labs or imaging studies, other than what we talked about with mammogram and MRIs, there's no indication for this for screening purposes. As you know, routine labs and other imaging studies have not been shown to improve survival outcomes or quality of life in asymptomatic patients. So this applies to lab evaluation, CT scans, PET scans. There's currently none of this is indicated for screening purposes as part of breast cancer survivorship follow-up. However, we do want to make sure to monitor for any new or unexplained persistent symptoms or changes, any physical changes, because if that's noted, certainly labs and diagnostics to evaluate those symptoms or changes would be very important. So when we talk about breast cancer surveillance, we're looking and watching for any signs of local recurrence, so any changes on the chest wall or the lymph nodes in the neck or axilla, but we're also looking for distant metastatic disease. And breast cancer can metastasize to various different locations, but the most common locations for metastasis are the brain, bone, lymph nodes, lung, and liver. So symptoms we want to watch for is any signs of frequent headaches that are new or different, vomiting, especially if it occurs first thing in the morning before you've had anything to eat, trouble with balance, trouble with significant changes in cognition or mood, any new masses anywhere, any unexplained cough, especially a dry, persistent cough, trouble breathing, any signs of abdominal pain or bloating, unexplained weight loss, jaundice, of course, and then any new bone pain that's persisting, especially along long bones, so back pain, hip pain, thigh pain, arm pain, etc. All of these are symptoms to watch for and to seek evaluation for to make sure they're not related to metastatic development from breast cancer. Now, you can certainly have these symptoms for non-malignant reasons, so the evaluation is important to rule out what the cause is. So a word on a specific histology of breast cancer, which is invasive lobular breast cancer. Invasive ductal breast cancer is the most common histology of breast cancer, but about 10 to 15% of breast cancers are invasive lobular breast cancers. And they do tend to have some slightly different metastatic patterns of spread. It can certainly, lobular breast cancers can certainly occur in all of those areas we talked about on the previous slide. But some unusual sites that it can present in is involving the eye, or so orbital area. It can involve the GI tract, so the gastric wall, small bowel, large bowel. It can recur in reproductive organs like the ovaries, and it also has a tendency to sometimes metastasize to the skin in a sheet-like form rather than a mass. So there's a slightly different pattern of metastasis sometimes that's seen in this histology. So watch for that. But bottom line is, if there's any new persistent symptom that's unexplained, that should be evaluated for all histology types. So in addition to watching for any signs of the primary breast cancer coming back locally or distant, we also want to be surveilling for any new breast cancer. So a number of large studies have estimated that the risk of a new primary breast cancer after the initial breast cancer diagnosis is increased to about 0.2 to 0.4% per year. So what that looks like, if someone lives 20 years after their breast cancer diagnosis, there's about a 4 to 8% chance of developing a second new breast cancer as long as there's breast tissue remaining. Now, some of the studies have actually estimated this risk to be higher, more like 1% per year, but there's some variability in predicted risk. But we do need to be watching for a second new primary breast cancer as part of our surveillance. And a new primary breast cancer can occur in the same side as your original breast cancer if there's breast tissue left on that side, or it can occur on the contralateral breast. Symptoms to watch for. So any breast masses, any breast pain, nipple discharge, skin changes of the breast, or any changes of the nipple areolar complex. We want to make sure you seek medical evaluation as soon as possible if any of those symptoms are noted, so we can determine if this represents a new breast primary. So kind of shifting gears from surveillance of breast cancer to surveillance and screening for other common cancers, because that's also part of breast survivorship. There are general population recommendations for routine screening for some of the more prevalent cancers, which are cervical cancer, colorectal cancer, endometrial cancer, and lung cancer. And breast cancer patients after completion of their active treatment should be following these screening recommendations, just like in general population. I will say there are several governing bodies that make recommendations regarding screening for these cancers, and there is quite a bit of variability in their recommendations. And sometimes insurance also follows one guidelines more than others. So there's a caveat to that. But generally speaking, looking at the NCCN guidelines and the ACS, American Cancer Society guidelines, these are some general summaries of recommendations for other common cancers. So for cervical cancer, any woman aged 21 to 65 is recommended to undergo cervical cancer screening. And this may need to continue past the age of 65 if their previous screening for cervical cancer revealed any atypical or concerning findings, or if they had inadequate screening completed prior to that age. And cervical cancer screening is typically done through pap smears and HPV testing. So for colorectal cancer, the screening recommendation currently is that all adults ages 45 to 75 should have colorectal cancer screening if they're of average risk. And the screening modalities used for this are multiple. So you can have colonoscopy, stool guaiac test, fecal immunohistochemical test, also called FIT testing, multi-targeted stool DNA testing, which Cologuard is an example of that, flexible sigmoidoscopy, or CT colonography. And the schedule for follow-up of these or schedule for these screening tests differ depending on which testing is being utilized. Endometrial cancer, there is not a routine screening recommendation for this, but because it is a prevalent cancer in general population, the recommendation is that all postmenopausal women should be counseled regarding signs and symptoms of endometrial cancer and evaluated for this if it's noted, and very specifically if postmenopausal women develop any unexpected bleeding or spotting, that should be evaluated, and part of the evaluation should be considering testing for endometrial cancer. For lung cancer, the screening recommendation currently is for high-risk patients, and that's considered to be anybody over the age of 50 who has a 20 or more pack year smoking history. For these patients, it's recommended to have an annual low-dose CT scan of the chest completed. Now, when it comes to screening, the screening for cancer, it all definitely depends on if the particular individual has a performance status to undergo these tests. and also if they have the performance status to be able to withstand interventions for these tests, if the tests show anything, any signs of cancer. So that's something to consider when making these recommendations and considering if it's appropriate for an individual. So genetic testing and screening, that's typically often done already in this part of breast cancer care, but if not, it's something that should be considered, and the patient should be referred for this if needed. And this should be something there's an ongoing discussion about family history as the patients are going through breast cancer survivorship, to make sure there's not new personal history or family history that's emerging where they do now need additional genetic testing or need to undergo genetic testing. If genetic testing is completed and a hereditary gene is identified, then there's different screening and prevention strategies that are recommended based on what genetic syndrome is identified. So if there's a genetic abnormality identified, then the screening would follow that instead of the general population screening that we talked about at the previous slide. So then now looking at late adverse effects of breast cancer treatment, because this is certainly part of breast cancer survivorship care as well. So breast cancer treatment can result in several different late adverse effects. And they're shown in this diagram below. There's certainly more than what's listed here. But as an overview, you can have memory loss, changes in mood, depression or anxiety. There can be chronic fatigue. There can be visual changes, peripheral neuropathy, lymphedema, especially in the upper extremities, pulmonary fibrosis, which can result from different treatments. And sometimes it's just a radiographic finding, and sometimes it's symptomatic pulmonary fibrosis. You can have high blood pressure, coronary artery disease, heart failure, weight gain, hemorrhagic cystitis, kidney function changes, hot flashes and night sweats, sexual dysfunction, including infertility, vaginal atrophy symptoms, and decrease in bone density. All of these things can be potentially late adverse effects associated with breast cancer treatment. So we're not going to go over, obviously, those list of symptoms and how to manage that, but I want to communicate that there's a team of people or healthcare providers that can help with these symptoms going forward as part of your survivorship. So certainly having your medical, radiation, or surgical oncology provider address some of these symptoms, and your primary care provider can be involved and help with managing some of these symptoms. There may be circumstances where cardio-oncology or cardiology needs to be involved. Pulmonology may need to be involved. Several centers have weight wellness programs that can help patients. Endocrinology or mineral metabolism may need to be involved to help with bone density or bone loss. Psychology, neuropsychology may need to be involved to help with mood changes and cognitive changes. Cancer rehab can be an incredible resource to help with various late adverse effects from breast cancer itself and its treatment. Dietitians to help with nutrition, maximizing nutrition going forward. And then social workers who can help with a variety of different aspects during cancer treatment as well as during survivorship. There's certainly specialists that's not listed here. There's infertility specialists. There's a whole long list of healthcare providers that can be involved in helping you manage these symptoms. So please do make sure you bring this up. I do want to focus on a few different late adverse effects that can be specifically problematic, and that's cardiovascular toxicity, changes in bone health, and infertility as late adverse effects from breast cancer treatment. So looking at cardiotoxicity, breast cancer survivors can be at increased risk of cardiovascular disease due to treatment related to cardiotoxic treatments that may be used as part of their breast cancer care. So one commonly used cardiotoxic agent is anthracycline. Adriamycin is the main anthracycline that's used in early stage breast cancer treatment. Another one is trastuzumab, commonly called Herceptin or known as Herceptin. Endocrine therapy, both tamoxifen and aromatase inhibitors can contribute to cardiovascular disease. Immunotherapy can sometimes contribute to cardiotoxicity, especially if it causes myocarditis. And then there's chest wall radiation therapy to the left breast or chest wall that can result in cardiotoxicity. Now, cardiotoxicity can be either immediate or delayed after completion of breast cancer treatment, and it can be permanent or it can be transient. So cardiotoxicity, what does that look like after breast cancer care? So the most common thing that we see is a decrease in left ventricular ejection fraction, which can lead to congestive heart failure. There's other forms. You can develop vascular disorders, arrhythmias, ischemia. So all these can be different forms of cardiotoxicity that may develop. So how do we surveil for this and manage this risk? So we want to consider increased cardiac surveillance for high-risk patients. So patients who have underlying cardiovascular history even before starting a breast cancer treatment, anybody with a strong family history of cardiac disease, and patients who receive these high-risk treatments that we talked about on the previous slide. For those patients, there should be there's an extra layer of surveillance for cardiotoxicity that we need to keep in mind. So if someone's considered high risk, often getting cardiology or cardio-oncology involved is often considered. Lifestyle measures that can be done to help decrease cardiovascular risk in general is smoking cessation, minimizing use of alcohol, maintaining a healthy body mass index, and regular exercise. And you'll see this theme, these 4 things coming up repeatedly and how it benefits in many different ways. And one of that is by decreasing cardiotoxic risk and cardiovascular disease risk. So bone loss is another potential late adverse effect to what I want to focus on. So bone loss caused by cancer therapy is significantly higher than normal age-related bone loss, and is estimated to be up to 80% in breast cancer patients in varying degrees. So what are some risk factors for developing decreased bone density as a result of breast cancer treatment? Well, when you have chemotherapy-induced premature menopause, that's a risk factor. If you have GnRH suppression of gonadal function with treatments like Zoladex or Lupron, if you're on any anti-estrogen therapy, especially aromatase inhibitors, and steroid use, especially if that's been a regular part of your treatment during breast cancer treatment, all of those things can contribute to decreasing bone density. So how do we surveil for that and manage the risk of potential bone density loss? So we want to make sure we get baseline bone density and repeated bone density every 2 years, especially in these category of patients who are at higher risk. So any postmenopausal women, any premenopausal women that are on tamoxifen with GnRH, like Lupron or Zoladex, and any women who are on aromatase inhibitors. All of these patients should be getting baseline bone density and then at least every 2-year bone density is done as part of their surveillance. And then ways to manage and promote bone density health is by doing weight-bearing exercises on a regular basis, avoiding tobacco use, limiting alcohol intake, and then calcium supplements. The general recommendation is about 1,000 to 1,200 milligrams a day of calcium, either in your diet or supplement, and vitamin D3 about 800 to 1,000 international units every day for adults over the age of 50. Now, what I'll say about the dosing of any medication is that you want to make sure you talk to your provider to make sure that this is the appropriate dose for you, because there are certain circumstances where that is not the recommended dose, or it may not even be recommended. So important to talk to your provider about your specific dosing that's right for you. We can also use bisphosphonates, whether that's oral or IV, as well as denosumab, which is a subcutaneous injection that can be used to either treat bone loss or prevent bone loss. And then the last late adverse effect I want to focus in on is infertility. This can be a potential long-term adverse effect associated with breast cancer treatment in women of childbearing age. So the most common chemotherapy agents that can cause infertility are alkylating agents. So the most common alkylating agent that's used in treatment of early stage breast cancer is cyclophosphamide or Cytoxan. Platinum agents can also cause infertility, and the most common one used is carboplatin. The most common one used in early stage breast cancer is carboplatin. And to some degree, so can taxanes. So taxanes or Taxol or Taxotere, and I'm using the brand name here because that's often what patients recognize as, as a medication that they've received. So all of these agents can result in infertility. We have limited data regarding infertility and biologic agents and targeted therapy, so there's more to be studied in that realm. So what can be done to manage this potential late adverse effect? It's important that that patients be referred to fertility specialists, either prior to the start of any systemic therapy, and then ongoing, as if patients are having difficulty with fertility following completion, then fertility specialists can be involved to help with that. So I want to kind of switch gears. So far we've been talking about disease management, about surveilling for breast cancer, screening for a new breast primary, looking for other common cancers, managing side effects of breast cancer treatment, etc. But I want to switch gears now to health promotion. So you see here a lot of healthcare provider or healthcare is treating the damage or treating disease, but we can also do much to turn the tap off and to decrease risk of potential damage and potential risk of cancer and other comorbidities. So that's what we're going to focus on in the rest of this talk. So healthy lifestyle measures can have a significant role in so many different ways. So it can certainly reduce the risk of breast cancer recurrence. It can have an impact on decreasing the risk of second cancers. It can reduce comorbidities or other health issues. It can decrease the risk of mortality, and it can improve quality of life. So what are the health promotion measures we want to focus on? So this is a diagram by the World Cancer Research Fund on cancer prevention. And if you see the red arrow on the bottom there, after cancer treatment is completed, or after active cancer treatment is completed, we're back on the same trajectory of trying to prevent cancer recurrence, and prevent any new cancers from occurring. So the same recommendations apply. So the recommendations generally are, be a healthy weight, be physically active, eat a diet rich in whole grains, vegetables, fruits, and beans, limit consumption of fast food and other processed foods high in fat, starches, or sugars, limit consumption of red and processed meats, limit consumption of sugar sweetened drinks, and limit alcohol consumption. The latter two part about not using supplements and about mothers breastfeeding, that's a topic for another talk, so I'm going to leave that and just focus on the other aspects of health promotion and cancer prevention. So talking about weight management, so there's the Women's Health Initiative clinical trial revealed that women who were obese had a significantly higher risk of developing breast cancer compared with women with normal body mass index. So several studies have shown that obesity in breast cancer patients was associated with larger tumors, positive lymph node status, metastasis development, shorter distant disease-free interval, and decreased overall survival in breast cancer patients. Another large group study, the Danish Breast Cancer Cooperative Group Study, revealed that obese patients had 46% higher risk of developing distant metastasis after 10-year follow-up compared to normal weight women. And it also revealed that this negatively impacted survival. There's substantial amount of evidence that obesity strongly influences risk, prognosis, and progression of various different malignancies. So this weight management has an impact not just on breast cancer risk and recurrence, but also on risk of other malignancies. So a really important factor to pay attention to. So here, there's some different proposed mechanisms of why obesity contributes to breast cancer cell growth. And some of these mechanisms are insulin resistance and hyperactivation of insulin-like growth factor pathways, increase in inflammatory cytokines and adipokines, and increase in levels of estrogen due to aromatization by adipose tissue. So all these different mechanisms potentially are thought to contribute to breast cancer cell promotion. So body mass index, I'm sure everyone hears about this often, so this is not new information, but as a review, body mass index is based on your weight and height and takes gender and age into consideration. And the World Health Organization and the NIH, the National Institute of Health, have categorized BMI in these following categories. So a BMI of 18.5 to 24.9 is considered normal weight. A BMI of 25 to 29.9 is considered overweight. A BMI of 30 to 34.9 is grade 1 obesity. And a BMI of 35 to 39.9 is grade 2 obesity. And finally, a BMI of 40 or more is considered grade 3 obesity. So looking at the chart, we certainly want to aim for a normal BMI of under 25, but the key sort of where the data with obesity is BMI over 30. So we want to reach for a goal of BMI less than 30, ideally under 25. How about physical activity? What is the impact that has on cancer prevention? And so there's several benefits associated with exercise and physical activity for breast cancer patients. So this can be in the realm of breast cancer prevention. Physical activity can decrease adipose tissue, decrease sex hormones, decrease oxidative stress, and increase stabilization of telomeres, all of which are important components of breast cancer prevention. Exercise and physical activity can also just help get you through medical treatment and recover from it. So it can help with weight loss and muscle mass loss. It can help decrease cardiotoxicity from treatment, and it can help with improving bone health. And then after completion of breast cancer treatment, it can have exercise can improve insulin sensitivity. It can improve immune and cardiopulmonary function. It can, again, help with bone health. It can decrease depression. It can and help improve sleep. So lots of different ways this can offer benefit. So what are the current recommendations for optimal physical activity in breast cancer survivors? We want to avoid inactivity and return to normal activity, physical activity as soon as possible after diagnosis. And in fact, there are several studies that show physical activity and exercise during chemotherapy have a significant positive impact on outcomes. So during and after it all, we want to encourage physical activity. The general recommendations about 150 minutes of moderate or 75 minutes of vigorous aerobic exercise per week, and at least 2 days per week to include strength training as part of your exercise. Nutrition, another big impact in health as a whole. So nutrition, eating a diet high in vegetables, fruits, whole grains, and legumes have been associated with 15 to 43% reduced risk of all-cause mortality. So significant impact across the board. But despite multiple studies, the effects of dietary factors in breast cancer recurrence is not clearly understood. So I can't, but although we cannot make specific recommendations as far as dietary impact on breast cancer, we've seen some general trends on what has a negative impact and what has a positive impact. So foods considered to have potential risk for breast cancer as they tend to increase endogenous estrogen, they tend to promote insulin-like growth factor and pro-inflammatory cytokines are simple carbohydrates, saturated fats, red meats, processed meats, and a high-fat diet. Although there's no conclusive evidence, the most common recommendation is to limit consumption of red meats to no more than about 3 portions per week, and generally limit intake of all of these aspects of nutrition that I've listed. Less is more when it comes to this. How about foods that generally known to have a protective role against breast cancer by reducing oxidative states and lowering chronic inflammation? Those include high fiber foods, polyunsaturated fatty acids like nuts, fatty fish like salmon, vitamin C containing foods, vitamin E containing foods, and fruits and vegetables. Again, there is not clear, specific data when it comes to breast cancer saying exactly how much of a benefit, but we do know the trend is the negative impact and positive impact. Those have held up pretty consistently in studies. And then finally, alcohol and tobacco use. So there's strong evidence that alcohol intake, regardless of the type of alcoholic drink, and regardless of menopausal status, is consistently associated with increased breast cancer risk. And why this might be, there's some proposed mechanisms of how alcohol might have a negative effect. One is that ethanol can promote epithelial mesenchymal transition. So epithelial cells are fairly stable, well-differentiated cells, and ethanol seems like it can promote a change of epithelial cells to mesenchymal cells, and mesenchymal cells are poorly differentiated and less stable. So this is thought to potentially promote tumor growth and metastasis, and also alcohol tends to increase estrogen concentrations. So based on this data, limiting alcohol intake to no more than 1 drink per day is recommended, and some studies actually recommend 3 drinks a day or less. Keeping in mind that 1 drink a day, you have to pay attention to serving sizes of what entails 1 drink a day. So again, less is better. And then smoking cessation. Numerous studies have demonstrated that smoking at the time of breast cancer diagnosis have a worse breast cancer specific and overall survival outcome than never smokers. And so it's encouraged that breast cancer survivors should discontinue smoking and avoid use of tobacco products to minimize risk of malignancies in general and other comorbidities. So that's a lot of things we talked about, and hopefully the key takeaway is, there may be some of these things that you're already incorporating into your lifestyle measures, but start where you are and use what you have and do what you can, because this allows you to be able to maximize your chance of having the best quality of life and the best health in general going forward. So with that, here are my references, and I'm happy to take any questions.
Thank you so much, Sheeba. That was extremely informative. And as a result, we have some great questions. So we'll get to those. If you have a question, have not yet submitted that, go ahead and open that chat feature and make sure you get that in so we can try to have you leave with an answer, at least some guidance to getting one. So our first question, Sheeba, is if you have dense breasts, is it recommended to get an ultrasound in addition to a mammogram?
So the current, when it comes to dense breasts, in addition to the mammogram, the general recommendation is to either consider a mammogram with contrast or an MRI of the breast. Those are favored over ultrasound.
Perfect, thank you. And then our next question, and I think you touched on minimizing alcohol intake, but there's a follow-up question to the potential conflict with alcohol and some of the medications mentioned. So for example, can someone have a nightly glass of wine within a serving size of wine while on letrozole?
So, you do need to check with pharmacy as far as specific, interactions with medications and alcohol. But generally speaking, yes, the recommendation is, again, less is more. But it seems that, 1 serving of alcohol per day is the maximum that's recommended. So I'll leave it to that. None is optimal, but of course, that is the current recommendation. Seems like that's a reasonable amount of intake.
Fantastic. And then in terms of strengthening bones, is Zometa recommended for bone strength?
That's a great question, and it's a complex answer. So it is an option. Zometa is an option for treatment for decreased bone density, both in the preventive and treatment settings in various aspects. But there are different things that determine if you are a candidate for Zometa. So that's something I would direct your provider to see if it's applicable. But it is utilized in that arena.
Perfect. Okay, and then this is a great question about survivorship care for our survivors who have long-standing clearance from a breast cancer diagnosis. So this was submitted by an individual who's 19 years post-breast cancer and is seeing an internal medicine physician who does their survivorship and overall wellness and monitoring. Can you weigh in on if we should be recommending an oncologist annually or when we transition to a PCP or someone else to manage survivorship care?
Yeah, sure. So, with the NCCN and the ACS ASCO guidelines, those are directed towards oncology or your primary care physician. So as long as the guidelines are being followed for the recommended, imaging, recommended history and physical exam, really it's the importance is that you see a provider. It doesn't have to be an oncologist. Now, that being said, you do need to get clearance from your oncologist to specify when it's okay to transition care out from oncology to your primary care based on your specific risk factors and concerns that they might have.
And I know here at the Cancer Center, our advanced practice providers often are overseeing survivorship care. So it may not be directly the oncologist, but in collaboration with an oncologist too.
Absolutely.
This question is about late adverse effects experienced by chemo. Can you talk about some of the late adverse effects of chemotherapy and equally what effect would those have on, what radiation effects might be longstanding?
So, the most common thing we worry about, most of the side effects from chemotherapy tends to be, shorter interval and tend to resolve over time. But with radiation, one of the things that we monitor for is, especially if someone has had radiation to the left breast or left chest wall, is any cardiotoxicity that can develop over time. So, it's something, it's important to see your primary care doctor on a regular basis for routine cardiac screening in that setting. But then with this added risk, there may be some additional surveillance that's indicated, especially if there's other factors like personal history of heart disease, a strong family history of heart disease. Although there's not a routine sort of imaging or a testing that's recommended, it is recommended that that is something that's followed for. Radiation and certain chemotherapies can increase the risk of a secondary malignancy over time. So that's something else that, again, a provider that's following you should be monitoring for.
Awesome. Okay. And then this question is in line with the nutrition data that you shared. Is it recommended, and I'll plug our nutrition team here at the Cancer Center, if you are being treated here with us, you have access to a dietitian who can answer some of these specific questions. But is it recommended to follow a dairy-free or gluten-free diet as a survivor?
So, one of the things that came across is that there is not conclusive data. So there is not a conclusive data that this should be done and this should not be done in breast cancer patients. And that includes dairy. There's not specific guidelines where we've been able to correlate, specific increase or decrease cancer risk associated with it. So short answer is no, but I would echo what Alex said, which is reach out to your dietitian and talk about potential ways that dairy might, have an impact, especially if it is, depending on, there's certainly some positives, the calcium and bone health, and then, but if it is, part of contributing to increase weight, say, that would be something that could have a negative impact. But directly, there's not conclusive evidence that I'm aware of that when it comes to breast cancer and dairy.
Great. Similar, how about alkaline water? Is it encouraged for survivors of breast cancer to focus on drinking alkaline water?
So there is no conclusive data that I'm aware of in that regard. And that there's so many studies in all different type of, nutritional intake, avoiding or increasing, that's been shown to have impact, but none of them have been conclusive, meaning they have not been repeated on studies and supported. So currently, those are not things that's recommended based on guidelines that we have available.
Right. Okay. And then a request or question about follow-up mammograms and MRIs. For someone who underwent a deep flap reconstruction, is it recommended for those patients to have ongoing mammograms or MRIs?
So if you've had a full, mastectomy on both sides, or if you've had mastectomy on one side, the side where you had the deep flap reconstruction does not require any routine screening, because that's really not breast tissue remaining anymore on that side. So that doesn't need any screening evaluation going forward. Now, of course, if someone notices a mass or pain or something that's different, then we do recommend imaging for that, but routine screening not indicated for reconstructed tissue.
Right. Okay. Okay. And then we have, let's see, one more question. Well, similar question. So is that the same thing with a full double mastectomy with implants? And I think you answered that as well.
That's correct. Yeah.
Okay. And then the last question I see, so you still have a chance, you have 3 minutes to get them in if you have some that have yet to be answered. What do you recommend, Sheeba, as follow-up and awareness for monitoring potential future recurrence after reconstruction? What tests help monitor?
So really no test. That's where the history and physical is the biggest component of finding any signs of recurrence in the reconstructed breast, or if you've had a full mastectomy and no reconstruction. It's really is if there's any new pain, new masses, skin changes, anything that the provider feels on an exam. So that's how we monitor for any recurrence in reconstructed breast, or when there's absence of breast tissue.
Okay, and this naturally leads to this question, which is about knowing if you might potentially have a cancer recurrence in the chest wall muscle if you're not having those screenings.
Yeah, so that's the thing with these screening tools. They're designed to study breast tissue, right? They're not designed to look at chest wall tissue. So if there is, so again, history and physical exam, and if you have new pain, to take a deep breath, new pain just on the chest wall, on exam, if the provider feels or you feel anything where it feels thicker, different, looks different, those all warrant, there are specific studies, whether that's CT chest or MRI chest or ultrasound, to be able to catch that, but none of that. So the large group studies that these guidelines were based on, doing routine imaging of the chest wall, did not seem to end up resulting in improved survival or quality of life in doing so. So it's really the history and physical is how we monitor for any chest wall recurrence following a mastectomy.
Well, thank you to all of you on our call today. Fantastic questions, and thank you, Sheeba, for answering those in such a succinct way and understandable way. Again, we so appreciate all of you spending time with us today, and appreciate you so much, Sheeba, for hosting this. And we hope that you'll continue to join. We are looking at future Lunch and Learns for 2024, so we really look forward to continuing this series with you, and hope you have a wonderful holiday season coming up.
Thank you, everyone.